Aloha! Welcome to ECHO. This CME activity is jointly provided by the Queens Medical Center and UH-JABSOM Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Geriatric ECHO for CME attendance purposes. As a reminder, evaluations are required for CMEs. You can find evaluations by following the link in the chat or at any time on our website and email advertisement. We offer free continuing education for this series when you complete our evaluations. Certificates are sent out the Monday after our educational series. Your comments are very important to the planning committee, and we will be using them to plan future programs. We want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO model goes, all teach, all learn. So it will take all of you to create this community of learning. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open the time up for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to topic of today's lecture. We only ask that you keep it HIPAA compliant case for discussion. That means please do not share patient's name, birthday, address, and so on. We learn best from our patients. They are the best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. Hi, I'm Wynette Gaylord, President of ARCA, Alliance of Residential Care Home Administrators. We have Maribel Tan, President of Foster Family Homes Association, Elsa Talavera from All Island Case Management Corporation, Danielle DeLonghi from Aloha Care, Leila Ventar from United Healthcare, and Dr. Rita Bell Fernandez from University of Hawaii. We cannot offer certificates of attendance for videos you have viewed, unfortunately. You must participate in our education live. We are now in the last month of a 4-month series on mobility. This month, we will be talking about caregiver wellness, and next month, we'll be discussing the importance of movement for health. It gives me great pleasure to introduce our speaker today, Miquela Ibrao, who is an assistant professor at the University of Hawaii at Manoa. She completed a dual MSW MPH at Washington University in St. Louis and a PhD in public health from the University of Hawaii at Manoa. She has worked with the Department of Geriatric Medicine on their Geriatric Workforce Enhancement Program grant since 2018. Her current work draws on community-based research methodologies to enhance Indigenous and kupuna health, reflecting her commitment to improve the well-being of Indigenous communities and community health through collaborative and culturally sensitive approaches. Welcome, Miquela, and thank you.
Thank you for that introduction, and thank you everybody for being here with us today. So I have been with the Department of Geriatric Medicine and the GWEP grant that allows us to do this care home echo for the last 5 years. And for 3 of those years, I was getting my PhD in public health. So today I'm here to share with you one of the studies I did for my dissertation. And it's a quantitative analysis of mobility limitations. So we'll get into what that means. But I based my dissertation off of the 4Ms framework, which is the model that we use to design the curriculum for this Care Home Echo series. The 4Ms are what matters, right? Mobility, medication, and mentation. And for this series, we spend about 3 to 4 months on each topic every year so that we can do a bit of a deep dive and talk about updates and how we address these with the people that we care for. The age-friendly health systems was designed because US public health organizations and our government have recognized that we do have this rapidly aging population across the United States that really needs high quality care and interdisciplinary care. We need a team of healthcare providers to help our patients. So US government and public health organizations worked with the Institute for Healthcare Improvement to package the 4Ms and create a model to encourage healthcare systems to adopt geriatric screening and quality care initiatives. The 4Ms are based on evidence-based practices that support healthy aging in a Western healthcare setting, including regular assessment of geriatric concerns that impact quality of care and longevity. So I'd been working with the age-friendly health systems model for about 3 or 4 years by the time I got to the point in my PhD program where I had to make a decision on what I was going to do my studies on. And what I kept thinking was that we had this 4Ms model that we were trying to implement in healthcare systems across the nation and in Hawaii, and that we are adapting to make relevant for community practice. But what if you come from a culture that doesn't really believe or understand Western healthcare? So I am Indigenous. I am Laguna Pueblo and Quetzal. I grew up in the American Southwest, mostly in Arizona and New Mexico, on and near reservations, and that is my ancestral homeland. So I wanted to share some of my elders with you today as we are starting. Here is my grandfather right here on the left, Edmund Jackson, with my mother. And then over here on the right is again my grandfather and my grandmother, Lorraine Jackson, holding
Dr.
my.
Ibrao, the screen
Yes.
isn't sharing.
Oh, thank you. Cancel it out. Good thing. Here we go. You can see them now, right? Yes? Okay. Here are my grandparents. And the only slide you really missed was that picture of the 4Ms that you see on all of our educational information. Sorry about that, everybody. So there's my grandparents. This is Ed Jackson on the left, and then Ed and Lorraine on the right. And they're the people that inspired me to go into geriatrics. My grandmother got a very rare form of lung cancer when I was in my late teens and early 20s, and I was very close with her. So we went through a process of about almost 10 years of treating it with different experimental drugs and, working with a very interdisciplinary team. And then we worked through palliative care and hospice. And I had a lot of respect for just how varied and caring the people that we worked with in addressing her care. They're both Indigenous mixed, and navigating a Western healthcare setting for them was somewhat difficult. We had a whole team of us. They have 7 kids and a ton of grandkids, but I was the only one that worked in healthcare. So it was very complicated navigating it. And finding, now that my grandfather is getting older, finding care that is relevant to him and what he really wants has been interesting as well. I moved to Hawaii in 2017 with my husband, who is Native Hawaiian and Filipino, and his grandmother spent the last few years of her life in a care home in Waipahu. My in-laws have a lot of respect and love for the care home that she was in. They still stop and talk with the caregiver that she spent her last years with. So I just wanted to, when I entered into this research, I had these people in my heart, and I wanted to share them with you today because we're looking at data, it's numbers, but those numbers represent people. And those are the people that we're really trying to touch and impact, and they matter. So the study I'm sharing with you today is my mobility study. My mobility in the 4Ms framework is defined strictly as physical mobility. It's an older adult's decreased ability to physically navigate their lived environment, which is associated with a decreased quality of life and an increased risk of falls. However, mobility can also be defined as an inability for someone to drive or to travel safely by themselves. But for the study's purpose, it was defined as physical mobility. Essentially, physical disability status is age-related, and as people get older, they're more likely to need help navigating their lived environments. Approximately 42% of older adults in the US who are over the age of 65 have at least one limitation to performing a daily task that is essential to their ability to age in place and in their communities. Access to resources that increase somebody's ability to maintain robust physical health and robust mobility is inequitable and impacted by what we call social determinants of health. Basically, physical activity, which is one of the recommendations to maintain mobility health, can be impacted by your neighborhood and built environment, or your ability to have a safe space and proximity to parks and recreational facilities. And it can also be limited by your economic stability in low income areas. Healthcare access and quality impact the ability of older adults to receive home-based physical and occupational therapy, especially for those in rural areas. And necessary home modifications so that you can stay at home safely can be an additional financial burden, or may require seeking out social services and resources, which may feel overwhelming for those who are less educated. So for this study, my major questions were, do different races and ethnicities experience different rates of mobility limitations in Hawaii? And do social determinants of health impact mobility limitations among kupuna in the study in Hawaii as well? Before we go any further, I wanted to stop and ask you guys, why do you think it's important that we know population health statistics? Why do we care how rates of mobility limitations in the state? I didn't drop them in the chat or on mute. Let's see if I can get the chat. Does anybody have any thoughts? Maybe some of our panelists? To provide better care. Thank you, Joseph. Yeah. Anybody else? To make more accessible paths. I like that one. Data helps us create programs to adequately address social determinants of health. Thank you, Sarah. These are all good. You have any more? To know they're basic.
May nako.
Yeah,
Ano ba sinasagot yan?
okay.
Kung nawala
Dahil
yung
pakalabit.
sound ko. Yeah.
Nawala yung sound mo.
Track health and disease. Thank you, Renata. Yeah, these are a lot of the ones that I have too. It helps us with resource allocation. So money from the federal and state government, to identify community health problems. Yes. So state and federal governments tend to look at these statistics and then divvy out the money based on these. They create programs based on these. They distribute grants like the GWEP grant based on these. It helps us with healthcare planning. So programs from healthcare providers usually look at these health statistics and prioritize based on that. It helps us know what our workforce needs are. Right now, we're pushing really hard to get more people trained in geriatrics because we know we have an aging population. And that's how we are able to get money from the government for things like GWEP. It helps us with policy development, knowing that we have an aging population. That's how the Social Security Administration was developed, right? It helps us with social research like this. It helps us validate it, right? And then we keep doing it and we keep tracking community health problems and advocating for changes. It helps us with environmental planning. City planners and urban planners look at these statistics to decide how they need to plan cities and what resources need to come in. Businesses do this a lot too. It helps us with advocacy and political representation. And it helps us empower communities. When we take this data and we don't hoard it at the academic level or at the government level, and we give it back to the community, it helps you understand your risk factors, the community's risk factors, and how you want to make change to help yourselves and your communities. So it's really important that we share this back so that communities can make the changes that they want based on their statistics. So for the study, I did a secondary data analysis of behavioral risk factor surveillance system from 2019 to 2021. It's very academic. That's how I would say it in an academic setting. But basically, the Hawaii Behavioral Risk Factor Surveillance System is a national survey. So have any of you ever gotten a call on the phone asking you to take a survey? You get a phone and they say, hey, can I have 10 minutes of your time and ask you a few questions? Or have you ever gotten mailer in the mail asking you to complete a survey and mail it back to get an incentive? I think I get that like once or twice a year from my cable company, where they ask me to fill out a form about my TV usage, or they pop up all of the time now on the internet. Well, you take a 10-question survey. I know we ask you at the end of every single one of these to do evaluations, but something like that. So the behavioral risk factor surveillance system is what we call a public health surveillance program. All 50 states and the US territories participate, and the state or the territory's Department of Health, with guidance from the Center of Disease Control, randomly calls cell phones and landlines across the state and asks people to participate in this survey. The survey it's long, and it's only asked to adults 18 years and older. It asks questions about their health-related behaviors, their chronic disease experiences, and their experience with healthcare access. Only community living adults are included, so those in congregate living settings, such as a long-term care facility or a shelter, are excluded. And from 2019 to 2021, 23,339 adults in Hawaii participated. The last thing I need to disclose is that this
Miquela, we cannot hear you. Miquela?
I don't think she can hear us. Miquela,
yeah, I
we can't hear you. See if we can message her directly.
Hold on. Can you hear me now? Can you hear me now?
Oh, we
It wasn't that loud.
can. Maybe you could speak a little louder.
Does this one work again?
That
Yes,
sounds
that
okay.
sounds.
Okay, I'll bring this closer. I don't know what happened there. I'm sorry. At what point did I cut out? 218. Okay.
Prior to this screen shot.
Right here then.
Yes.
We got through that. You saw 23,000 participants.
Prior to that.
Oh, okay. Did you guys hear about what the BRFIS is?
No.
No.
Okay, so the Hawaii Behavioral Risk Factor Surveillance System is a survey. You know, have you ever gotten a call on the phone and they've asked you, hey, will you take a survey? Or you get one in the mail. I get one like once a year from my cable company asking me to take a survey and they'll pay me money. That's what it is. The Behavioral Risk Factor Surveillance System is a public health surveillance program. So all 50 states and the US territories participate, and the departments of health randomly call cell phones and landlines in the state and ask people to participate in a survey. So you have to be 18 years and older. The survey is really long, and it asks you questions about health-related behaviors, chronic health diseases, and healthcare access. So in Hawaii, between 2019 and 2021, 23,339 people participated. And to do this study, I had to make sure that it was ethical. And they don't let researchers just decide that their research is ethical. You have to go through oversight boards to make sure it is ethical. So this was approved by the Hawaii Institute Review Board and the Hawaii Department of Health. I had to ask the Department of Health they don't just give you the entire sample set. You have to ask for a very specific questions that you want. So these were my questions. And then I had to go through and clean it for my study population. I have it here in case you're really interested. For the most part, the only thing you really need to know is that I cleaned it so that we're looking at people 55 years and older who are of one of the 4 major race and ethnic groups in Hawaii, which are white, Filipino, Japanese, and Native Hawaiian. And yeah, so my total sample size was 10,039. When I ran my statistics, I did descriptive statistics, which are those bean countings. 50 people said yes, 130 people said no. I also did prevalence, which tells you how common mobility limitations are within the people that responded from the study. But to save on time today, we're just going to be looking at the odds ratio tables. So don't zone out on me now. Like, I know that this looks very confusing if you haven't taken a course on statistics and know how to read them, but we'll walk through it together. Odds ratios tell you the likelihood of something occurring. So it's the likelihood of a mobility limitations given that you are Filipino, or you are over the age of 75 and Filipino, or that you're female. Odds tables are what Las Vegas uses for their betting, right? What are your odds of winning every time you sit down at the slot machines? What are the odds of your sports team winning? So that's what we are calculating here. The first column is the crude odd ratios, and that means you run the test without making any adjustments. Adjusted odds ratio are the thing that we're really looking at. And that means that you run the test taking into account life factors that could impact the outcome. So in this instance, I took into account those demographic statistics, your age, your race, your ethnicity, your income level, all of the social determinants of health went into calculating the score to get the most correct and reflective number, the most corrective odds of things to occur. This last column right here, this p-value, tells you whether or not the test was considered significant. The test is significant, or you can actually interpret it if it's above 0.05. So I highlighted in red the ones that were insignificant. Everything else is considered significant. We're getting down to the results. After adjustments were made, Native Hawaiians were 1.4 times more likely to have mobility limitations compared to whites in the state. Age showed that you have an increased odds of experiencing mobility limitations the older that you get, which is what you would expect from what we know about the body's natural aging process. And that was true across all races except for this Native Hawaiian bloc. They were less likely to have mobility limitations between the ages of 65 and 74 as they were between 55 and 64. But this is most likely due to the high rate of Native Hawaiians who had mobility limitations by the age of 55, and it may be impacted by life expectancy as well in this category. But this is why it's important for us to have the descriptive statistics to help you interpret at the end. Women had higher odds of experiencing mobility limitations than men in the total sample and among white and Filipino participants. They were less likely to have mobility limitations among Japanese participants, and the Native Hawaiian category was insignificant. Social determinant of health economic variables were education, health insurance, and income. Education level in the overall population showed that the more education that you have, the lower odds you have of experiencing a mobility limitation, which is what we expect given the social determinant of health framework. This was true across all of the races and ethnicities in the study. However, it had less of a protective factor for Native Hawaiians. But in the Native Hawaiian group, you can see that Native Hawaiians with some college and technical school were 18% less likely than those with a high school degree, and 19% less likely if they had a college degree or more. Meanwhile, when you're looking at this white bracket, you can see that the white population was 35% less likely if they had some college or technical school, and 61% less likely if they had college or technical school or more. And our health insurance, we can see that health insurance resulted in a higher likelihood of mobility limitations, but this was perhaps because of the high number of insured that we see across the state. In fact, when we disaggregated this, less than 50 respondents who were Filipino, Japanese, and Native Hawaiian indicated that they didn't have health insurance. So I couldn't show those odd ratios in this table. And then here we have income. Income resulted in a protective factor across most of the races and ethnicities, except for Filipinos. But I think that was the unknown category. A lot responded. This 1.94 is very large here in the unknown category, and it was because a lot of respondents indicated that they didn't know or refused to respond. The social determinant of health social variables were walkable neighborhood, marital status, and island of residence. Walkable neighborhood acted as a protective factor for everyone except for Filipinos, where the association was found to be insignificant, again, perhaps because of that unknown category. Marital status was protective for all groups, although Native Hawaiians were slightly less likely to develop mobility limitations when they were married compared to other groups. And those who did not live on the island of Oahu were less likely to have mobility limitations than those who did. So key takeaways that we took from this study were that Native Hawaiian kupuna have higher prevalence and odds ratios of reported mobility limitations than other groups, and that social determinant of health indicators were associated with mobility limitations. However, they impacted different groups differently. So for Native Hawaiians, who were the focus of the dissertation, economic variables were less protective than social variables, which was interesting. We get to limitations. It's always important for a researcher to point out the limitations because this tells you a little bit of how reliable the findings are while you're trying to interpret them and apply them. Limitations for this study were that the data was collected between 2019 and 2021, which was the peak of COVID. As we all know, COVID came with a lot of mobility limitations where people couldn't leave their house. So it could have a very big impact on mobility that we haven't seen yet. We also had that very narrow definition of mobility where it was just that physical mobility, and we know that mobility is larger than that. The BRFIS is what we call a cross-sectional survey. So it doesn't follow one participant over a long period of time, which means we can't make conclusions about causation. We can't say because you are female, you are going to have mobility limitations. We just can say it's associated. We can see a link there, but it's not the cause, right? And then lastly, we could have gotten stronger results if we'd looked at a framework that wasn't a Western framework. We were using the social determinants of health framework, which is based on a Western dominant US interpretation of health. But if we'd used an indigenous determinants of health framework or a different framework based on culture, we could have gotten results that were more specific to the population that we're actually looking at. As an example of that, this is an indigenous determinants of health framework where you can see adverse policies and historical traumas pictured at the root of the tree create lifelong impacts in future generations, which are pictured at the leaves. So at this point, I think we can pause and open up for some questions in case anybody needs clarification. And then I wanted to go into recommendations. I'll pull my chat. I'm so sorry we're having tech issues today. Okay. Does anybody have any questions based on the study right now?
Not thus far, thank you.
Okay. Now, given these, we want to think about what kind of recommendations can we actually make that would empower communities and make a difference. For the dissertation, I had a few major recommendations. The first was that we need to promote healthy mobility across a lifespan. Studies have found that mobility in older adults is impacted by mobility behaviors that we adopt when we're young and then maintain throughout our lifetime. So physical activity promotion programs often have age requirements, right? You have to be below the age of 18 or above the age of 65. And then we have this middle group of people that are a little left out. So removing age limitations to promote health across the lifespan could help maximize healthy mobility. I also really like the idea of developing intergenerational programs because I have young children. And I realized that when I had young children, it's hard to be active while you're carting them around. So having programs and communities where grandparents and parents and children can all be active together and practice health, a healthy home, right? A healthy community would be really nice. And I think decrease barriers to participation in these classes. I think it's also important that we promote health behaviors based on motivations and values that are relevant to the communities that we're serving. So designing exercise and mobility programs that incorporate traditional activities. I've really liked the hula classes that you see, or the Tai Chi classes that you see that Sarah talks a lot about. The powwow classes where I'm from have been a very big hit. Anything that engages movement and encourages people to actually come and participate together based on their values. Second, I think we need to promote mobility as long as possible, but mobility loss is a natural part of the aging process. And at some point, we're all going to have a problem with that. Loss of mobility can feel overwhelming and like a loss of freedom and independence, which can come with feelings of frustration and grief, which needs to be acknowledged, and mental health supports need to be provided. I think incorporating families with education on mobility loss and how to support their loved ones could be very positive. Communities should be designed with inclusivity and access for all individuals, including those with mobility limitations, so that they can easily navigate and access public spaces. And programs, resources, and policies really should prioritize the reduction of barriers around community dwelling for those with disabilities. This could look like an increase in community safe living spaces, affordable in-home social service programs, home modifications, and assistance with activities of daily living. And that is, just to wrap up, the dissertation findings were published in the Journal of American Geriatrics recently. Our major finding was that the 4Ms model is really effective and evidence-based, but in order to truly be effective with all communities, we need to incorporate a fifth M of multicultural. Culture has such a big impact on the way that we experience health and engage in healthy activities. And healthcare providers need to be taught how to approach multicultural clients in our culture. The publication I can give to John to put up on the website if anybody's interested in reading it. I also did an interview with Hawaii NPR that we can post for people to listen to as well, if they're interested in hearing a little bit more about the results of this study and future directions for GWEP and aging and cultural practices, I guess, in aging. And that is all I have to share with you today. Thank you.
I don't see any question in the chat, so maybe let's proceed to the evaluation, John.
There's the
hold on.
evaluation. I did want to give people some time to share resources on mobility, if we had some time. So here are some that I thought of. There are mindful movement classes in a few organizations. There was this one I was looking at earlier. Still Moving Center. The Hula Kahiko Intermediate. Workout Rollout, Tai Chi, Oli. Methods of Strength, and this is live online for people who can't go in person. Here's some baby hula cultural immersion courses, which you can go with your keiki to dance, which I like. There are wheelchair yoga classes. This is something that I did with my grandmother a lot towards the end that I love. Trying to stay active and talk about wellness of mind, right, and your mental health. I like that aspect of yoga. especially as she was getting towards the end. The YMCA has a lot of senior activity classes that they offer. And I know over COVID, they started offering these online and recorded as well. I don't know if they still do, but certain gyms will have these then now access online that you can go to. And then here's an example of an intergenerational fitness course that I also really liked, where you have just movement together, right? And I can post these in the chat for people to look at. Sarah says, Lanakila Multipurpose Senior Center has over 100 movement and other classes with minimal annual fees. I really like Lanakila too.
This may sound redundant, but I also do like the OC 16 at 9 a.m. So that's the Kupuna hour. So they do, strength training, just full mobility things. And yes, I'm going to say you can't just park them in the front of the TV and leave them alone. You have to watch them and guide them through the class.
Okay. Does any of our other panelists have anything to say?
Miquela, Daniel and Maribel couldn't make it,
Oh, okay.
and I don't see Elsa.
Yeah, that's fine. Well, then let's move on to the evaluations. Layla, would you like to talk about the evaluations?
Yeah, sorry, I have to turn off my video just so I can speak. So when you're doing the evaluations, I believe these are the questions that you'll encounter. 4 questions. How many residents do you have total? How many of your residents feel unsteady when standing or walking? How many of your residents worry about falling? How many of your residents have fallen in the past year? Okay, well, so please remember to complete the evaluation, and John share that in the chat, the link to the evaluation. In order for you to receive a certificate of attendance, make sure that we have all the correct information. We have your correct email address, your first name, your last name, all the people that have attended with you. It has to be filled out for each person in your group. And please make sure to check your spam folder if you don't get it in your primary inbox. And that's it. We thank you for all that you do, and thank you for your attendance and attention to our meeting this afternoon.
Thank you again, Miquela, for your great leadership, stepping in. We appreciate it. Doctor,
Yes.
have a great day. Thank you so much.
Thank you, everyone.